and welcome. Hello to all of those of you that I know out there. I can see quite a few of you who I've met in the past. Appreciate you joining us on the webinar today. The webinar's focuses are going to be on a family treatment model, keeping families together and building protective factors. And we decided to focus on this. I provide consultation to the National Indian Child Welfare Association and their system of care grantees, and a large part of my life is working with tribal communities and developing sustainable behavioral health services, and the other half of my life is working with rural healthcare clinics, integrating into the primary care clinic settings mental health and substance use services. So a lot of my work relates to more rural environment, certainly, and how to ensure that there's access to care. So I'm really happy to be presenting on the family treatment model and bringing to you some live things that are happening across the country and some of the communities I work in. Mostly the family treatment model is happening in tribal communities. So today, well, let's see, I'll get this clicking away here. You need to know that it's hosted by the conference or webinar is hosted by the National Indian Child Welfare Association, a partner of the National TA Network for Children's Behavioral Health, operated by and coordinated through the University of Maryland. And we thank them for making this possible to bring this information to you. We'll back up one here. The agenda today is a family treatment model, a treatment case for family unity. Why should we keep families together? A business case, so the financial side. And lastly, if this is something that is of interest, how do you get there? How do you make this happen? I was talking earlier with Vicki Wolf of the National Indian Child Welfare Association about this webinar, certainly, and this work. And what I find so valuable is that the work that I'm doing around this model has been organic and really initiated by the tribal communities themselves. This isn't coming down in terms of a funding stream from a state or federal level, but rather recognition within the tribal communities of the importance and value of families and children staying together, or at least creating systems that do that. So for today, we're going to look at the family treatment models, learn a little bit about lifelong health of family and the implications of separation, which probably for most of you, you know more than I do about that. Understanding the financial costs of separation, looking at what is a business case model to why or how you should keep families together, and then learn steps that tribal communities can take to enhance their current health system around a family unity model, and then simply to understand what the opportunity is and how you might move forward with it. So I'll start with the family treatment models, and please, as you go, if you have questions, make sure you put it in the public chat so that Vicki and Tiara will be keeping track of that, and we'll get time at the end to answer questions and try to bring some resources your way. So family integrated treatment services to American Indian Alaska Native families, what is that? There's a mental health side, and those are some of the activities that you would have in that, and there's a substance use disorder services. So not to confuse anybody, but in the payment world, we've kind of moved from chemical dependency treatment to what's more called substance use disorder services. So rather than labeling a person as being chemically dependent, we're saying that they have a diagnosis that fits under that substance use disorder services. So together, the two of them, when you combine mental health and substance use disorder, you're talking about behavioral health services. And in the family integrated model, the idea is mostly how and what the service menu, you might say, do you need to provide services that keep families who are at risk of children being placed outside the family? How do you work with them together to make this happen? And before I dive in more deeply into the forest on this, keep in mind that our current child welfare family services are really have been developed and are managed in such a way that financially it sort of encourages family separation. And I don't mean that in a blunt and sort of negative feature, but child welfare systems and child protection services and child family services have money available for them because children are placed outside of the family. The models we're going to be talking about are how you keep those families together and still maintain your child welfare system and have revenue that supports that system being in place to be able to initiate and monitor and surround families with services. So we really are coming at this in the communities I work with in a way that we recognize that there's a financial sort of investment to keep families apart. And part of what an organization or a tribe has to be able to sell is how you keep families together and financially make that sustainable over time, which that's most of my job, what I do. So back to the treatment model itself, when you look at this, we're talking about identifying the target population. And in most family treatment services, when we talk about sort of the family unity model, we are looking at starting with the families initially who may have more success or opportunity more success so that you can learn from them. And these are the kinds of services you'd put. You'd identify the population, have intake processes, do individual family crises, psych testing, educational events for both mental health and substance use. The emphasis so far has been more on the substance use disorder side because in the child welfare system or child protection system, those are the families who have sort of popped up as being more at risk and in need of more intervention. If you work in the business, you know that if somebody has a substance use disorder, there's likely to have an accompanying mental health disorder or diagnoses, and so we would term that co-occurring. There may also be a physical medical diagnosis that's chronic that may accompany this. So knowing that the population comes with special needs and a need for more intensive services is really important. The clinical goals of trauma treatment is really increasing our awareness about how intergenerational trauma has affected people's lives. It's doing everything you can to sort of support that family, but certainly understanding who's walking in the door, what's the background that they bring with them, and knowing that trauma's there, that there's multiple losses, that there's a sense of not being able to trust oneself. There's usually involvement with a substance of some kind. There's a feeling of hopelessness. There's a real need to increase resiliency and move away from more of that maladaptive self, because in our world, one of the sort of pillars, you might say, to this kind of treatment is that you recognize that whatever the behavior that the person is doing in an effort to manage their life, it's the best that they know how at the time. So a lot of this is really understanding that and not judging, but saying the person's doing the best they can given what they know and their experience in life. And the family-centered treatment model is going from there and starting to add some tools that move away from that maladaptive self to the more resilient person, to uh, you know, increase their success, their ability to manage their life, and do it in a way that supports them and supports their children. So lots of really good clinical goals that can be put in there to help assist a person. Another whole set of reasons that you'd want to do the family-centered trauma treatment approach includes increasing sort of self-behavioral management, managing some of the triggers that go on, improving communication skills. One of the areas that we've spent a lot of time on is really educating parents regarding the developmental stages for children and parenting skills that go with that, and the associated sort of feelings in terms of being able to manage it successfully, having challenges, and learning in a peer environment. So you'll see that there's really a host of goals that we want, but mostly we want to provide parents with the skills to be able to manage their family themselves and do it in a way that they have success. I will tell you that in terms of a family-centered treatment approach, that we're talking intensive and longer-term engagement. So it wouldn't be unusual that the family treatment model might be residential to include the family, the intensive side might be 6 months to a year in nature, and then step downs into less intensive environments and more ability to move about and practice things, but it is a very intense kind of treatment approach. The other side of that is families get separated, and it is more difficult to get them back together once the separation has taken place. So when you think about this, think about, is there an outpatient model that might work, or is there opportunity for more residential type of model as you go forward? But we'll talk more about that when we get into the business side of this. So the treatment model really looks at this in terms of a more intensive is that this really becomes the parent or the adult's job. 23 hours of co-occurring treatment, meaning mental health and substance use, with access to physical health care, a nurse or a physician or a prescriber should you need that. And the children have about 3 hours of work. In the moderate section, you can see it goes to 14, and the children continue at 3, and then they step down to a more of an outpatient model of 4 hours. So a rather intensive approach, and it's one in which there's a cohort of families together if you're doing a residential kind of model, and moving it from that those families moving along together as much as possible and gaining strength from each other. And it's a host of groups, multifamily groups, and certainly a great deal of individual work. The substance use side is more based on an intensive outpatient substance use treatment model, so anywhere from 8 to 11 hours of the treatment time that's directed at substance use disorder, whether it be trigger management, life skills, certainly skills around understanding their addiction. So one piece of this is, of course, anytime you go into treatment, is that you have a care plan, and that is something that happens at the front end, that the services are such that we found the most success in the two environments that have adopted this about 1.5 years ago, is when the families are together and they move through it, and you certainly have folks who drop out and you add new folks in. The nature of the illness, you might say, in terms of substance use. But the success side is that we're learning more about how to move folks a little more efficiently from the intensive to the moderate. to the outpatient side. So there's learning and economy and efficiencies as you do more. And you're right, yes, the hours are per week. So thanks, Kari. So the idea is this really becomes the person's job in a residential treatment environment. We have had folks that initially they start with that high level and they also are able to maintain a part-time job, or we're working with vocational rehab and employment offices to try to provide access to revenue to do this for the families to be in this in a way. So I will say, just to add some color to this, that in your community, if you were to do the family treatment model, you'd likely have partners to include law enforcement, child protection services, could be tribal court, could be health and human services, that really there's a huge partnership of folks who together try to ensure that the family's basic needs are met and that the struggle for food, like in one of the settings, they actually, in terms of food stamps, they actually pool their food stamps and use that money to buy food that fits the whole community. Now, and there are some restrictions in some states or some counties around that, so you have to work with understanding that if you're the provider side. Along with the treatment professionals, probably the most important staff person in the family treatment model is the care coordinator. So that's the person who really ensures that the participants have some kind of healthcare payment, whether it be a Medicaid, whether if they're employed, a healthcare insurance. But that person works with the adult to ensure that, at least from the cost of providing these services, that's paid for, and then the other partners work to ensure that the basic needs, food stamps, and work, if that's possible, that those pieces are in place. So the treatment case, this really is more, why would you go in this direction? Why would you want to treat families rather than to look at people individually and approach it in that manner? And I can tell you, as someone who early in my career ran residential programs, worked as a social worker in them, and ran them, that separating kids from their families, you can be successful. The kids learn how to behave in their new environment, and that when they go back home, they don't have the skills to maintain themselves in that family structure, and the costs emotionally and financially are significant, and there's great research to support that. So treatment philosophy. Again, we know that whether mental health or drug or alcohol or substances, that those are close together. I've run a number of crises services and mental health services, and it's rare that you don't have somebody who may be in crisis that also has an accompanying occurring or comorbid presentation to them. The trauma treatment is essentially the biggest foundational piece in doing this work, that you understand the impact of trauma and are really asking more what happened, not what did you do, but what happened, and understand that individual as well as the family's experience with trauma in their life, and that becomes a huge part of the clinical side of the work. And in one of the programs, the team took a really, we did a 6-month ramp up to build the program. So the team sat down, it was a tribal environment, sat down and looked at trauma within the community and began to develop a workforce that was trauma-informed, a manner in providing care that supported cultural, traditional wellness and healing opportunities as a way of working that into the treatment program. So the treatment philosophy certainly started with a trauma informed foundation and looked at the natural opportunities within the community, the natural deficits that are there and the gaps, and began to put a treatment philosophy that more represented the community through the lens of a trauma-informed treatment approach. So in how that translates into a treatment side, you can see we're talking health, fitness, nutrition, is that the program includes learning about foods, even indigenous foods, looking at exercise, looking at healthy educational processes to increase sort of health literacy, you might say, within those, and certainly spirituality, reconnecting members to the spirituality of their choice in terms of what they believe would be helpful. And one area that we've seen pretty consistently in the clinical side of the work is that folks who are at risk or have had their children removed, there's a real sense of loss and lack of confidence in themselves, and in some ways almost a sense of, if you might think of it this way, having a bankrupt soul. And so the work there, not only is it mental health, substance use, it's the spiritual, it's the whole person. So being able to think about your philosophy in that regard. The integrated treatment approach, relationally based worldviews, understanding that, having key pieces to it in terms of the work that you present and the opportunities for the family to be engaged in their treatment, and certainly knowing that treatment and sort of recovery within that process is a self-described process, is unique to that individual and that family. The beauty of that more group or multi-family sort of approach is that there's examples in abundance of how the families are working together and making things happen. So integrated really includes the physical, the health, the mental, substance use, spiritual, cultural, and it's how you weave that all together that essentially helps to begin to shape the kind of work that goes on. The intensive outpatient program model, you can see it has a lot of components throughout it in terms of, does it happen in groups? Is it individual? Is it psychoeducational? And sort of what does a typical IOP program look like in a day? And in this model, there's 9 hours worth of it that has a lot of group involvement. I will say that the other side of that in the treatment approach is the psychoeducational pieces that you're doing with the person individually, with their family, the parenting groups, the nutritional groups, lots of activities that while the IOP may be a framework, might be the frame of the house, you might say, all of the other pieces really add the decorations and put the pictures, and you can see where 23 hours a week could get utilized and put to work fairly quickly, and certainly in a way that it becomes a job of the parent and the family in terms of the whole treatment. The mental health side, again, less intensive in the sense of groups are certainly a part of it, but different than the IOP model, and much more looking at the, what evidence-based practices or promising practices or practice-based evidence approaches might fit here. And you can see the range of those. I will say in our work in the tribal communities, we've really worked hard to identify culture, traditional practices around wellness and healing that can be built into this. And for those who may have lost that connection to their culture, to provide opportunity to reconnect, to understand it, to get education from elders and members of the tribe who've been ascribed some of that cultural history and practices. So the treatment team, you might say, certainly is involved with the folks who provide clinical work in which you can bill and get paid. I will say that probably the more significant pieces are how you involve those natural supports within the community. Strategies, you can see here that they wouldn't be much different than if somebody were coming in to your setting individually, referred, but the approach at it is much more intensive. And we're working from starting at those triggers to working around towards how one more cognitively understands, say, codependency issues or relapse prevention, family. So starting with those things that impact the person's everyday life, and understanding in terms of therapeutic approach that mental health, substance use disorders are much like a physical illness, and there's chronicity to it, and to understand that and to understand there's recovery and there's cycles to a person's recovery and wellness, and that sometimes people relapse and need to be involved with psychotropic medications, to help manage some of the physical side of it, to allow that brain and the neurotransmitters and receivers to talk more efficiently together. So the use of medication-assisted treatment for folks with opioid disorders is utilized. And we also see that when there's chronicity in terms of physical health, that you need to understand how medications play a part in this and how utilizing all the tools make it more effective. So in the team we've had mental health and substance use. We also have physical health folks, spiritual folks. Again, I can't overemphasize the importance of an integrated approach in providing care, which starts from that most intensive level to over a year to a year and a half, moving to outpatient kind of an environment. So child and family therapies, so there's a focus to this with the children and the family as well. You can see a host of approaches that are used. This goes back to the team, and as a team, really looking at the members of your team and what kind of approach might be most helpful in terms of the work. Where do folks come from? How does it relate to the co-occurring presentation of the family member who may have created the risk within the family in terms of children being outplaced, the impact to children and their well-being. So you can see a whole host of sort of approaches and strategies, and I will leave sort of how this fits to those folks who are most clinically engaged. That's where I started. It's not where I'm at today, but I see Dr. Warrior's on the phone from Nebraska, and I'm sure Dr. Warrior and many of you others who are more clinical in nature could describe what these are and how they fit within providing services. What I do know is that all of these are developmentally approached in a very developmental fashion with the age of the children, and we, in the centers that we've been, we currently are seeing more younger children than we are seeing teens. So might be, infant, early childhood mental health specialties up to about age 10. And then we see sort of a leap up to then teenagers, so who are 14, 15, 16 in coming into the setting. And again, that just simply requires a different approach and in terms of how the model is applied. This just gets back to what do you want to do when you're doing child therapy, and so it's much more clinical approach that relates to the task, the goals that you would like to achieve. And again, if we go back to the previous slide, you can see the multitude of approaches that could be utilized to, in effect, work with the children in an age-appropriate and developmentally appropriate manner. Mostly what we see is the restoration of intimate relationships, the movement away, especially for folks who are substance use involved, the movement away from seeing people around them as objects to the creation of relationships that have some reciprocity to it, that have some depth to it, and less sort of object thinking and object behavior. So child therapy is a very specialized kind of approach, and in many states there's now certification for infant and early childhood mental health services. In the states where they're not, it's worthwhile, I think, to have somebody who gets trained in that model. Parent-child therapy, again, another piece of this is working with the parent and the child together on their relationships, having multi-parent groups or family groups where they can work together and learn from each other. And you can see, again, the activities and the goals and what's being stressed. Really trying to create an environment that families can learn from each other, can love each other, can have productive strategies and coping skills as a part of their approach as a family. The cumulative hours of family or co-occurring treatment, you can see this breaks it down in terms of that intensive family therapy model and sort of what goes on. So this just gives you a snapshot of the work that goes on. This is another how you might look at it from a schedule, breaking it down. If you were interested in starting something like this, what would it look like? How would you be able to explain it to yourselves? This is a morning session. Sorry about this slide. It's I couldn't break it up to make it more conducive to reading, but you can see that it goes into the evening. And you can see where work might be problematic because of the high level of participation in this. And so we've seen that as folks have spent 3 to 6 months doing this, that they're better able to then land employment and be able to feel satisfied in terms of both doing their treatment, bringing in some money for their family, sort of beginning to carve out the future for them. Again, later in the evening. What I would say about schedules is that think about, this is really important to think about the lives, the daily life of the families who you're working with and what's important to them and how to structure this. I will say in a more intensive model, it like I said, it's a job. It's part of what they got to do to move towards recovery. But certainly there's lots of room for adapting and leaving some time for the family to be a family, having some space. In one setting that we have created this, it's an old convent. And actually the apartments is almost like a college dorm in a sense. So there's a great deal more visibility in terms of the family, what's going on and how they interact both within their apartment and within the complex. And another one, it's more apartment-like. And so, and a third one that we've developed has been much smaller. So it's a kind of like a duplex, where there are 4 families in there. They have shared common space, and they, have their own private rooms. But it's a treatment environment that is as family-minded as you could make it. But it is and does represent the intent of keeping the family together and having intensive services. So what's the business case model for family treatment? What are the elements that you have to pay attention to, and why would you want to go down this route? Well, you can start with, the health outcomes that you'd like to see, improved well-being, permanency, decreased number of children out, reduce family separations, reduce trauma, all of those things. First, what I would say from if your community is looking is determine what's important, what is the goals that you would like to achieve, because that will help design how you best do the intervention. I have a belief that one should work within cohorts, that you set the number that you'd like to have in there, understand that there will be families who will drop out, there will be families who need more intensive services, some who need less, some who have more extended family involvements. You might start with a parent and one child, and pretty soon they have two other children that at some point are going to join. So there's some complexities to this, but the cohort model really is one that allows for a sense of I'm not alone. There are other people who are experiencing this. It begins to take away the shame and the guilt. And you have to understand it from a business side where you certainly have to have families in waiting. So one of the things we worked really hard at was understanding the target population. What are the characteristics of the families that you think you're going to have the most success with right away, in which you can learn from them and they can learn quickly and move towards success? And then the second cohort, having understanding that it may be a little bit more difficult. You've expanded your criteria. You've decided to focus on folks who there's more chronicity to their presentation. And so that's sort of how it begins to go, but I can't say enough about having a cohort model and understanding where you start and how you add and lose families over the course of not just 1 year, but maybe even up to 4 years. So let's talk a little bit about, there's a cost to this, providing this level of care, and how you begin to think about that in terms of the number of clinical events with staff members who are licensed and billable, and what does that turn into in terms of sustainability? Any session, so you look at the number of sessions that are billable. So in the model that it presented in here, we talked about 23 hours. Probably only 15 hours of those are billable, in the sense that you might have psychoeducation, you might have folks who are non-billable providing some services. So first you want to look at who are those folks that are billable. Are they licensed clinical social workers? Are they licensed chemical dependency addiction services? Are there peer recovery support counselors? Are there nursing or primary care docs who could be part of the delivery system? So part of that is to figure that piece out. The next is to look at, within the family, how many members are there and how many billable events would there be within that family system? The biggest trouble we've run into is not the intensive side of the services, but finding the clinical team to be able to do the work. That's been a harder process in the system. The other is then structuring from a most intensive sort of environment like the convent or environment to housing. So in the models that we've developed, we've really learned a lot about tax, you might call it Section 8, but there's even a move where there's tax incentives to have housing that is free over time. So there's a whole housing piece of this that requires some effort to understand, and that we've, in each of the systems, we've engaged the tribal housing folks to help us begin to understand and look at the implementation side of this. So what I would say is, don't think 6 months, think 4 years. Not necessarily that a family is going to be there, but in terms of sustainability, where you start today and what it could look like 4 years from now, and how you as a providing system have to think about sustainability and encouraging that families have access to resource over time. The revenue, if it's a tribal environment and the family members are tribal members, and if your state particularly has expanded Medicaid options for family members, you have the full sort of continuum of payment opportunities. If the state in which you reside, there is no expanded Medicaid, it makes it more difficult. Not totally difficult, because traditional Medicaid would be a single parent with a child who has, poverty, under poverty level income, could provide access to care and Medicaid as the payer. So part of this is just understanding who's at your door, who you want to serve, and what the payer sources are. It may require negotiating with Medicaids or with managed care companies in terms of the number of billable opportunities weekly. So what I would say is, in one of the programs we started with, the ramp-up cost was, I think it was $700,000. The first year revenue over expense for doing this was $500,000. The third year revenue over expense was close to $9 million. So what that tells you is that doing the work could provide revenue streams that could be utilized to go back into preventative and building protective factors within communities, housing, maybe it's sober living, maybe it's recovery housing, but that in the end, doing this right, there would be a revenue surplus that could be injected back into prevention, maintenance, well check kind of services that support families staying together. So I just talked about startup costs. This simply represents the 288 to, if you bring on your clinical team and pay their salaries, this is what it's going to cost you to have them in place and ready to go on day one. So what I want to emphasize here is you can't just jump into this, that there's a cost at the front end, and you'd want to be prepared for that. Operating costs, you can see this just takes a look at a model, and mostly these are numbers. I just wanted them to be reflective of you. Can you still hear me?
I can hear you.
Okay, thank you. My looks like my earbuds canceled out on me, so give me 1 second. Apologies for that. Technology wasn't on my side today. So this gives you just an idea of, when you look at your operating expenses, what it could be. And again, this is work that can be done pretty easily to help identify for your community what that would represent. The most important part is so that's the total expense. Here's the revenue opportunity in terms of net income over that. And you can see that over time, revenue side of this is pretty darn good. And again, it gets back to how then you re-inject that revenue over expense back into your prevention and maintenance, which is certainly something I would encourage. Again, just another look at cash flows and where you start and where you end. The business development steps, if we can spend a few moments at that, because I know I'm getting into the weeds with this, but really is back to what are the goals that you'd want for your community. So I always think of the world in terms of what are the number of families who are potentially at risk of their children being placed outside their home, and maybe even, you could go to the risk in terms of a diagnosis with mental health or substance use or co-occurring presentation and the implications for the family. So who are we really talking about? How many? And what might be the accompanying diagnoses to that? And then, so we figure out the end. So how big or small of a program do we need? And once you have those numbers, you can begin to look at the professional staff or the staffing you might have and the costs that are associated to it and some of the outcomes that you want to have. But it does make sense to have a business plan and approach this as a business in terms of its development. That we're going to look at, like I said, compelling needs, capacity, who pays for this becomes a big piece of this. I'm not going to spend a lot of time here, but I think what's important to know is the costs of a child in foster care are significant over the life of that child who's in foster care. They're higher utilizers of the healthcare system. They're higher involvement in terms of corrections. They're higher involvement in terms of law enforcement. So anything that we can do on the front end to begin to support family unity, there's a lifelong savings that goes with it. We want to make sure from an operational capacity, like I said, how many, who's there, how do we do this, and really have this piece down in terms of the continuum of care. Not only do you want that intensive side, but you want to be able to have and allow for people to step down, whether through success in the program or if somebody drops out, you still want to have services that can keep them engaged, again, with the idea that folks would continue to step in. The last piece is the payer source, and again, we're mostly talking Medicaid. We might be talking braiding some of the state and county and federal dollars that could support this. In that case, you're probably working with a managed care company, whether it be a Beacon Health, a Magellan, an Optum. My experience with them is if you have a model in mind, you've done all this front-end work, and you meet with them, that they're much more willing to talk with you about, the number of sessions, talking with a bundled care rate, where they pay you one fee per family to provide all those services, over and above the traditional fee-for-service model. So being planful, having a plan, understanding your community, understanding your approach, helps you be a better partner when it comes to how you secure the revenue to support your work. One way, again, back to, understanding the opportunity or calculating the financial viability and sustainability is really, again, think about the encounter rate for those of you who are able to access that for the members, and the number of events that might occur in a day. In some states, and not all states, because it varies from 1 encounter per day to 5 encounters per day, that think about it this way. If you have a family member engaged in this work, so 1 mental health encounter is $455, 1 substance use disorder encounter is $455, 1 engagement with a healthcare professional, a nutritionist, a nurse, a primary care is another $455. So really the revenue side of this is available at the encounter rate, but also if you're going to get the state rate for providing these services, all that can be negotiated. And again, so having a good model with that in mind is much more helpful for calculating the viability of the involvement. This is just another step in looking at viability where you say, well, how many folks are there? What do I think their number of sessions are going to be? Who are the providers? It's my way of beginning to understand how to develop a sort of a one-page financial viability look at it, and then how you calculate those dollars by session, by number of sessions, and This can fit into one page, so if you were going to share with a business council or a tribal council what the opportunity is and why, these 4 steps that I'm going through can be put on one page and are really very easily presented, or they can be put into a infographic model where you sort of guide through this, so it's really a one-page look at it. And lastly, what would you do with the revenue over expense in terms of having these services? Where would you put those? Traditional healing, cultural events, anything. My bias is anything that's protective for families and youth. I'll give you an example, and I apologize if some of you may have heard this before, but one tribal community I worked with, 3,000 members, they had a healthcare clinic that on average, each member visited 3 times in a year. That provided a revenue surplus of about $3.5 million to the clinic that could be reinvested in the community. The council bought into the notion that they wanted to invest in health within their community members and decided that they wanted people to come in 20 times a year. Taking this model and looking at it, if you went from 3 to 20 over 7 years, the outcome side of that is $23 million revenue over expense. And people going 20 times, then you're beginning to recognize things early. You're having less of the contract IHS money going to cancer, heart disease, and diabetes because you're doing the upfront work. So the win, we're 3 years into this project. They've gone from 3 visits on average to 7 visits on average and revenues of $9 million. So there's a win in terms of the community's awareness about prevention, wellness, maintenance, and being able to look at, where do you invest this so that your community has healthier members. And they're actually conscientiously thinking about health and the importance of well checks and maintaining good health. So again, I'm probably on my soapbox with this, but there is good reference to support that this has a real win for a community in the long run. So the work that we've been doing, I want to add one more piece that's not in the slide here, that recently we started what's called upfront assessment. And this is to target families. If you don't have this intensive model in place, the upfront assessment is working directly with child welfare to identify those families where there is risk of children being placed out of home for a variety of reasons, and to identify that population and create an outpatient model to begin to provide treatment to help those families stay together should there not be a more intensive opportunity for them. So the good part of this is these programs I'm talking about, they're started because the community identifies that there's a need, that children are at risk, that family separation is at risk. So the upfront assessment does just that. It's a team who does that assessment of the family in terms of their basic needs, in terms of the psychological needs, their health needs, and begins to put in place an opportunity for the family to participate in a recovery model, much like what we've been talking about, but less intensive. And again, it has some of the same features where you build a team that's more of an informed trauma approach, that's focused on understanding the community, how to utilize the natural supports in the community to include culture and traditional wellness and healing. And this is the one that challenges the old model of child welfare where you get money when you have kids in placement. This begins to challenge that by taking the money that you're able to receive as a part of providing services to support your child welfare system to be in place to certainly serve those families where child separation or relative family foster care is a better choice to be in place but the model I so much like because it was generated in the community, and it's an alternative to get started in terms of preparing to look at a more intensive treatment approach. So I think I better stop there and give you opportunity to have questions or for me to clarify anything that I've said, and thank you very much for listening. So Vicki or Tiara, if you can help facilitate any questions, that would be great.
Dan, how long have you been working on this keeping the family together model within our community?
It's been a 2-year process. And I tell you what we did first is we did a business model. So we developed the business side of it and identifying the health implications, the health needs of the community, the numbers of children or families who are at risk, pulling the stakeholders together, child protection, law enforcement, courts, state agencies that might have an involvement, and certainly the tribal entities, to begin to design it and to do the training of the team. I don't do the clinical training, but finding folks and doing the training with the clinical team. And in the intensive model, the residential team that's going to be there, who are usually what we'd call peer support specialists. So they're folks who have a lived experience with a mental health or substance use diagnoses themselves, or a family member, or involvement with the system. So we try to ensure that the people doing the work are all folks who have a heavy investment in a recovery model and in a trauma-informed approach. So we're talking, I'm trying to think of the numbers of families that we've moved through. And within a year and a half, I think we had 9 families per cohort. And so far, I think we have 36 families who've moved through. We certainly have a dropout rate. Families who maintaining sobriety or their recovery is not happening, and the agencies whose job it is to protect children sort of step in. So you work with all those variables. On the other hand, we have 36 families who are together, who are in recovery, who have jobs, who are going to school, who those children have, I believe, a greater chance to have a fulfilled life by the work. I see there's a question about family peer support. Marilee, it really depends on what state you're in. So some states have in place a certified peer support training process. In there, some states sort of separate it with substance use or recovery support services for substance use, peer support for mental health, and a parent peer model for parents. And some put them all together. So again, it depends on your state. I'd be happy if you email me and let me know where you're at. I'd be happy to do the groundwork to tell you what's available. I'm a huge believer in peer services, have started peer-run organizations, and continue to support peer support as a way of intervening, because one thing we know is there's a peer in every community. And in the tribal communities I work, it's actually even more acceptable to be a peer, whether it be mental health or substance use, than it almost is to be that licensed, credentialed, master or level provider. Thanks, Marilee. Any other questions that might be helpful?
It looks like we have a couple of folks typing in their questions, so we're going to give them a little bit more time to get those in.
And I will say that the selling point, with tribal council, if it is because there may be upfront costs, or even in the system of care communities, as you look at your goals and the work that's going on, while I know that budget's set year to year, there might be opportunity to integrate some of this with other grants that may be out there or other investments the council might want to make. The front end has a load from a cost and a personnel side, but the back side of it is you really could be delivering a service that has a revenue surplus and can be reinvested. And the beauty is we're keeping families together. And I grew up in the system that separated families. And I will tell you, this is much more satisfying. I don't see any other questions being typed. Maybe I'm not. Maybe I need to scroll it. There we go. Any more questions coming your way, Tara?
Nope, I don't see any more questions posted so far. I do want to remind folks to please stay connected so that they can take the survey, the TA Network survey, about 5 minutes or so. So please stay connected or click that link in the public chat box. So I would say let's give it about another minute or so for any incoming questions, and if not, we can go ahead and close out.
Great. Well, thanks all of those of you who stuck around, and the slide deck is available to download. And if you have other questions, please feel free to reach out. I'm happy to answer those and provide any guidance in terms of where you might get started and what resources you might think about in terms of a family treatment model. The model that we are working with was initiated out of Compton, California, in what's called the Exodus program. And the gal who initiated it, they have years of exceptional work and success. And she, from a clinical side as well, has been able to make herself available, whether it's just by telephone call or email. So the Exodus model based out of Compton, California, and the gal's name is escaping me at this moment. And I did not put it as a reference, but if you write me, I'll be sure to give you that contact information. Thanks, everybody.
Thanks, Dan.